Good morning, everyone. Today I'm going to talk about the control of arterial blood pressure, the different factors or controllers of the arterial blood pressure. The blood pressure is very important to ensure continuous flow of blood throughout the circulatory system. First, I will go through the objectives of today's lecture. First objective is to understand the concept of mean arterial pressure and the factors that determine that pressure. Also to understand the relationship between cardiac output, total peripheral resistance, and the mean arterial pressure. And then to understand the different mechanisms involved in the regulation of mean arterial pressure. Here we'll see that there are short-term controllers, intermediate-term controllers, and long-term controllers of blood pressure. And finally, I will outline the location and roles of veno-atrial low pressure stretch receptors. These are a type of baroreceptors, but they are stimulated by lower thresholds of blood pressure. The mean arterial pressure is the main driving force for propelling or pushing blood to the tissue throughout the circulation to the different peripheral tissues. This pressure must be closely regulated for two main reasons. The first reason, this pressure must be high enough to ensure sufficient driving pressure, because without this driving pressure, the brain and other organs, including the heart, will not receive adequate blood flow, no matter what the local adjustments are made in the resistance of the arterioles supplying them. So even if the local regulatory mechanism will lead to vasodilation of blood vessels in these organs, without this pressure gradient, whatever the vasodilation that happens, there will not be any increase in the blood flow to those vital organs. And I'm talking mainly about the brain and the heart. On the other hand, this mean arterial pressure should not be so high that it creates extra work for the heart and increase the risk of vascular damage and the possible rupture of small blood vessels, especially the capillaries. The capillaries, they have very thin wall. It is just a basement membrane and a single endothelial layer. If they are exposed to very high pressure, they will rupture and they will lead to bleeding, for example, in the brain, and this can lead to stroke and death. What is the mean arterial pressure, or what is the definition of the mean arterial pressure? It is the average pressure driving blood forward into the tissues throughout the cardiac cycle. The term average usually means that we add this diastolic blood pressure to systolic blood pressure and we divide that by 2. But this is not the case. The mean arterial pressure is not halfway value between systolic and diastolic pressures, because the arterial pressure remains closer to the diastolic than to the systolic pressure for a longer period or portion of the cardiac cycle. At rest or at resting heart rate, we know very well that 2/3 of the cardiac cycle is spent in diastole and only 1/3 is spent in in systole. So again, I repeat, at rest, 2/3 of the cardiac cycle is spent in diastole and only 1/3 is spent in systole, because the cardiac cycle, 1/3 of the cardiac cycle duration is systole and the other 2/3 are diastole, which is a passive process. Therefore, the equation for the mean arterial pressure is we add 2/3 of diastolic blood pressure to 1/3 of systolic blood pressure. And if we just rearrange things, we can come to this commonly used equation, which is diastolic blood pressure plus 1/3 of the pulse pressure. Pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. For example, if the systolic is 120 and diastolic is 80, so the pulse pressure here is 40 millimeter mercury. Mean arterial pressure and not the systolic, neither the diastolic pressures, is the pressure that is monitored and regulated by the different homeostatic mechanisms in our body. So our body regulates or controls the mean arterial pressure rather than controlling systolic or diastolic pressure on their own or separately. Now, what are the determinants of the mean arterial pressure, or what are the factors on which the mean arterial pressure depend? The first factor, which is number 1, is the cardiac output. The mean arterial pressure depends on a great extent on the cardiac output. The second factor is the total peripheral resistance, or TPR, because we know very well that there is an equation, or the mean arterial pressure equation is the product of cardiac output and total peripheral resistance. So if the cardiac output increases, the mean arterial pressure will increase. The same if the total peripheral resistance increases, then the mean arterial pressure will increase. If both increase, we have much higher increase in the mean arterial pressure. The third factor that affects the mean arterial pressure is the blood volume. A decrease in the blood volume, for example during hemorrhage or dehydration, will decrease the venous return. And we know very well that a decrease in the venous return will lead to less or lower stroke volume, which in turn will lead to less or lower cardiac output. And if we decrease the cardiac output, according to the above equation, the mean arterial pressure will decrease. A fourth factor is the elasticity of the blood vessels, because we know very well, especially for the large arteries, they are the elastic reservoirs or the pressure reservoirs in the body, because they have abundant amount of elastin fibers in their wall. So elasticity of blood vessels, a decrease in the elasticity of great vessels, such as what happens during atherosclerosis. The vessels won't distend to receive the ejected blood during systole, and this will significantly increase the mean arterial pressure. As you can see here, we have 4 factors. Some of them can be modified by different homeostatic mechanisms, like the cardiac output, where we can play with the heart rate, stroke volume, or the total peripheral resistance, where we can play with the radius of the blood vessel or the blood viscosity, and also the blood volume, where the kidney can play a very important role in controlling the blood volume. The fourth factor is not easy to modify, so it is a non-modifiable factor that affects mean arterial pressure. We can delay the progression of atherosclerosis by changing the lifestyle, but we cannot change that for the immediate control of the mean arterial pressure. So these first 3 factors are the factors that can our body, through different homeostatic mechanism, adjust the mean arterial pressure. And in today's lecture we are going to discuss these factors one by one, and we'll start with the cardiac output. As we know, the cardiac output is the product of heart rate and stroke volume. So cardiac output is equal to heart rate multiplied by the stroke volume, and the heart rate is controlled or modified by the 2 divisions of the autonomic nervous system, the parasympathetic division and the sympathetic division. We know very well that the parasympathetic activity will reduce the heart rate, while the sympathetic activity plus epinephrine from the adrenal medulla, they increase the heart rate. So if we have an increase in the heart rate, this will increase the cardiac output, which in turn will increase the mean arterial pressure, and the opposite will happen if we have an increased parasympathetic activity. For the stroke volume, it is under the extrinsic control of the sympathetic division of the autonomic nervous system plus minus epinephrine from the adrenal medulla. Both of them can increase the contractility of the heart. Contractility of the ventricles, an increase in the contractility of the ventricles will increase the stroke volume. Also, the sympathetic activity, in addition to epinephrine, they can cause venoconstriction. Constriction of the veins, which are the volume or blood reservoirs, because we know that large percentage of our blood volume is present in the systemic veins. So if the systemic veins constrict in response to sympathetic activity or epinephrine, this will lead to an increase in the venous return. An increase in the venous return through the Frank-Starling law of the heart will increase the end diastolic volume, which in turn will increase the stroke volume or the force of contraction that is generated, and an increase in the stroke volume will lead to an increase in the cardiac output, which in turn will increase the mean arterial pressure. So the mean arterial pressure depends on cardiac output and total peripheral resistance, and we know this equation. Mean arterial pressure is the product of cardiac output and total peripheral resistance. Cardiac output depends on heart rate and stroke volume, as we have seen in the previous slide. The heart rate depends on the relative balance of the parasympathetic activity, which decreases heart rate, and sympathetic activity, including epinephrine from the adrenal medulla, which increases the heart rate. Stroke volume increases in response to sympathetic activity, which is the extrinsic control of the stroke volume. Also, the stroke volume increases as venous return increases, and this is an intrinsic control of the stroke volume according to the Frank-Starling law of the heart, because an increase in the venous return will stretch the cardiomyocytes, and according to the length-tension relationship, this will lead to generation of stronger force of contraction during systole. Now quickly let's know what are the different factors that affect the venous return, because an increase in venous return will increase the stroke volume and cardiac output. So the cardiac output depends greatly on the venous return, and we know very well that whatever blood volume received by the heart during the diastole, which is venous return, it will be ejected, exactly the same volume will be ejected from the heart during systole. As you can see here in this figure, we have the pressure gradient. So if we have a greater cardiac output, this will make a higher pressure imparted to the blood by the cardiac contraction during ventricular contraction or ventricular systole, and this will increase the pressure in the arteries, capillaries, and also in the veins. So there is a higher pressure gradient that ensures more blood to return to the right atrium during the venous return. Another important factor is the sympathetic activity. An increase in the sympathetic vasoconstrictor activity will cause venoconstriction. The venoconstriction will increase the pressure in the veins, and this will increase the gradient between the vein and the right atrium, and at the same time will decrease the venous capacity, because we know the veins are the blood volume reservoir. Another also important factor is the skeletal muscle pump, because as the skeletal muscles, especially in the lower limb, will contract with intact valves in the veins, they will help in the propulsion of blood back to the heart. Another also important mechanism is the respiratory pump, because we know that during inhalation the intrathoracic pressure will be negative, and this will decrease the pressure in the chest veins and will ensure a higher pressure gradient for the venous return during diastole. There are other factors like the cardiac suction effect, and this happens mainly during vigorous exercise. Sudden, quick ventricular diastole will create cardiac suction, a sudden decrease in the ventricular pressure, and this will ensure a higher pressure gradient for the venous return from the veins through the right atrium to the right ventricle. Another important factor that is also important in controlling or affects the venous return is the blood volume. If we have higher blood volume, this will increase the venous return. High blood volume means we have higher venous pressure, and we have higher pressure gradient between the vein and the right atrium, and this will lead to a better venous return. Blood volume is affected by the renal salt and water retention, and also by another factor, which is the passive bulk flow shift of fluid from the interstitial fluid into the plasma, and I will discuss this in one of the coming slides. So these are the different factors that affect venous return, and as I said, if we change the venous return, we can change the stroke volume, because this will affect the preload, and if we play with the preload, we can affect the stroke volume, which in turn will affect the cardiac output. So venous return, according to the explanation from the previous slide, is enhanced by sympathetically induced venous vasoconstriction or venoconstriction. We can use both terms, by the skeletal pump and by the respiratory pump. All of them will enhance the venous return. Also, as I said, the cardiac suction, and this is during ventricular diastole, especially during excessive or vigorous exercise. And venous return can also be increased by increasing the blood volume, which in turn depends on two factors. As I said, the size of passive bulk flow fluid shifts between the plasma and the interstitial fluid across the capillary walls. And this is considered as an intermediate controller of mean arterial pressure, as we'll see in one of the coming slides. Also, the venous return depends on the salt and water balance, which are hormonally controlled by the renin-angiotensin-aldosterone system and the hormone vasopressin, or antidiuretic hormone, that is released from the posterior pituitary gland. And these two hormonal systems are under the long-term or considered long-term controllers of mean arterial pressure. Again, I will explain that in one of the coming slides. Now let's talk. We finished talking about the effect of cardiac output on the mean arterial pressure. Let's go to point number 2, the effect of total peripheral resistance on the mean arterial pressure. The total peripheral resistance can be changed by changing either the arteriolar radius, the diameter of the arterioles, or the viscosity of the blood, or changing both of them at the same time. As you can see here, the arteriolar radius or diameter depends on two important controllers: local or intrinsic controllers and extrinsic controller. If we are talking about local, the main local controllers are the local metabolite or metabolic changes in oxygen and other metabolites, as we'll see in one of the slides, including potassium, adenosine, accumulation of other metabolites. For the extrinsic control, the main extrinsic controller of the arteriolar diameter is the sympathetic division of the autonomic nervous system, because as far as we know, the parasympathetic plays minor or no role in controlling the radius of the arterioles. For the local control, we have other factors, which is the temperature, like heat and cold. Heat will cause dilation, vasodilation. Cold will cause vasoconstriction, and the temperature is used for therapeutic uses. We have also a concept that is called response to shear stress. So blood flowing through a blood vessel, this blood flow will stimulate the endothelial cells to release factors that can cause vasodilation. We have another response, which is called the myogenic response. Sudden stretch in a blood vessel will cause its vasoconstriction, and sudden release of that stretch will cause vasodilation of the blood vessel. Other factors in the local or intrinsic control is the local release of histamine, like in allergic reaction and during inflammation. Also, we have other extrinsic controllers, and these are mainly hormones: the hormone vasopressin from the posterior pituitary gland, the peptide angiotensin II, which causes vasoconstriction, and the hormones epinephrine and norepinephrine from the adrenal medulla, and norepinephrine also from the sympathetic postganglionic fiber terminals. In addition to the arteriolar radius, we can, or the total peripheral resistance is also affected by blood vessel viscosity, and if we increase the blood vessel viscosity, I'm talking about the blood viscosity. If we increase the blood viscosity, the total peripheral resistance will increase, because there will be higher friction between the blood and the vessel wall, and this will increase the resistance. Blood viscosity depends mainly on red blood cells. It is mainly depending on blood cells in general, but since we know that red blood cells are the most dominant cells, so it depends mainly on red blood cells. Another factor also that determines the blood viscosity is the concentration of plasma proteins, and we are talking mainly about albumin. So the total peripheral resistance depends on two factors, as I said: the radius of all arterioles, most important factor determining the total peripheral resistance. Arteriolar radius is influenced by local or intrinsic metabolic controls that match blood flow with the metabolic needs of that tissue locally. And we have two extrinsic controllers: the neural control, which is sympathetic control mechanism, and the hormonal extrinsic control mechanism, mainly through the hormone vasopressin and the peptide angiotensin II. The other important controller or determinant of the total peripheral resistance is the blood viscosity, as I explained earlier, and this depends on the number of red blood cells and the concentration of plasma proteins. But the main factor determining the blood viscosity, or factor number one that affects the viscosity, is the number of red blood cells, the erythrocyte count. Now let's talk about the control of mean arterial pressure. What are the factors that control the mean arterial pressure, and how do we classify them? Because there are some factors that come into action immediately once the blood pressure changes. Other factors come into play later on, and other factors, they come later on, so they need longer time to produce a response or to affect the blood pressure. So let's go through these factors one by one. The control of mean arterial pressure is under short-term control, and here we can see the response within seconds to minutes. So the response is immediate, and here we have three important reflexes, and one of them is the baroreceptor reflex, the chemoreceptor reflex, and we have the central nervous system ischemic response. So these three, the baroreceptor reflex, chemoreceptor reflex, and CNS ischemic response, are short-term controllers of the mean arterial pressure, and they will bring about changes in blood pressure, trying to bring it back to normal within seconds or minutes. Then we have the intermediate term controllers that need minutes to hours to bring about their effects, and these are renin-angiotensin vasoconstrictor mechanism, where we depend mainly on the angiotensin II response, and the stress relaxation mechanism that I will explain later on, and the capillary fluid shift mechanism. This includes shift of fluid through the tissue capillary walls in and out of the circulation to readjust the blood volume as needed, because a change in the blood pressure or mean arterial pressure will affect the capillary hydrostatic pressure, and this will affect the net filtration pressure, so we'll have less filtration and more reabsorption, so fluid will move from the tissue back to the capillary, okay, depending on the blood pressure level. The long-term control mechanism for mean arterial pressure, which needs hours to days to bring the response, is the renal blood volume pressure control mechanism that I will explain in one of the coming slides. As you can see here in this figure, how the different controllers of the mean arterial pressure come into effect in terms of time. Here we have on the x-axis the time, seconds, minutes, hours, and days. We can see that the baroreceptor, the chemoreceptor reflex, and the CNS ischemic response, they are short-term controllers of mean arterial pressure. Then we have the stress relaxation mechanism, the capillary fluid shift, and the aldosterone system, or the renin-angiotensin aldosterone system. They are intermediate controllers, while the renal blood volume response control is a long-term controller of the mean arterial pressure. Let's start with the short-term control of mean arterial pressure. The baroreceptors are mechanoreceptors that are present everywhere in the circulation. in the arteries, in the veins, in the atria, in the systemic circulation, in the pulmonary circulation, so they are present everywhere. But whenever we mention baroreceptors without giving a prefix to that, we mean the arterial baroreceptors that are present in the aortic arch and the carotid sinus, just in the proximal part of the internal carotid artery after the bifurcation of the common carotid artery into internal and external carotid arteries. So we have the aortic arch baroreceptors and the carotid sinus baroreceptors. The fibers or the afferents are present in the vagus nerve for the aortic baroreceptors and the glossopharyngeal nerve for the carotid sinus baroreceptors. The cell bodies also are present in different locations, the petrous ganglion for the aortic arch and nodose ganglion for the carotid sinus baroreceptors, but the terminals are present or are conveyed to the same nucleus or the nucleus tractus solitarius, which is the motor nucleus of the vagus nerve. So here we have the baroreceptor reflex. Baroreceptors are stretch receptors that sense changes in blood pressure. We have different types of stretch receptors in the circulation. We have the high pressure baroreceptors, and these are the arterial baroreceptors that I have already explained here on the right side of the slide. And we have the low pressure receptors. These baroreceptors that are stimulated by low pressures, and we call them venoatrial baroreceptors. Also, we have other baroreceptors elsewhere in the circulation, and I will give some examples on them in one of the slides. Arterial baroreceptors are located in the aortic arch and the carotid sinuses in the internal or the proximal part of the internal carotid arteries. In this slide, we will see the response of a single arterial baroreceptor fiber to changes in pressure. The arterial baroreceptors regulate the arterial pressure by increasing the firing rate when they are stretched. So a high pressure will increase the firing rate. So here we have an arterial baroreceptor that is firing when the blood pressure is within the normal range, and we can see this firing pattern. If there is hypertension or an increase in the blood pressure, the firing rate will increase. So there is an increase in the firing rate when the baroreceptors are stretched by high pressure, and they decrease their firing rate when they are relaxed. So a hypotension or a decrease in the blood pressure will lead to a decrease in the firing rate of the baroreceptors. And as you can see here, we can see that there are two patterns of responses. So there are two types of responses. We have the static response S and the dynamic response D. So when the blood pressure is constant, we have a certain frequency of firing rate. Then if the blood pressure increases, we can see a sudden increase in the firing rate that it will decrease a little bit and becomes steady. So this increase in the firing rate that will last for a short time is called dynamic response. After that, the firing rate will decrease and remains static or constant for a while until we have the next change in blood pressure. So here we can see a drop, sudden drop in blood pressure. There is no firing, and this is considered as dynamic response 2. So either an increase in the firing or no firing in response to high pressure or low pressure respectively. Then the firing will resume after the while, after the dynamic response is over. Again, we have the firing rate S1 because the blood pressure returned to levels before or pre-increase levels. So we have again the S1 or static response 1. You can notice very well that the firing rate in S1 is less than the firing rate in static response 2 because during S2 the blood pressure is sustained high. What are the types of high pressure baroreceptors or arterial baroreceptors? We have two types. We have A fibers or type A, and we have type C. You can notice we have two types here, the C fibers or type C and A fibers or type A, and you can see the difference in terms of threshold. A fibers, they have lower threshold for stimulation. C fibers, they have higher pressure for stimulation. The A fibers become saturated at earlier pressure. So saturated means they cannot increase their firing rate beyond a certain level, which is 150 here. And C fibers, they become saturated after 220. So they have differences in their threshold sensitivity and their saturation. So type A or A fibers, they are highly sensitive. They are activated at a range between 30 to 90. So here in this figure, it is around 60 millimeter, the threshold. They have high firing rate. As you can see, they can reach very high firing rate compared to the C fibers, but their maximum firing rate is reached at 150 millimeter mercury. So they become saturated earlier compared to the C fibers. The type C baroreceptors, they have a lower sensitivity. As we can see, they have higher threshold before firing starts, and they are activated at range between 70 to 140 millimeter mercury. In this figure, it is around 100, which is around between in this range. Therefore, type C fibers, they can deal with higher pressures than type A, because type A fibers around this pressure, they will become saturated. Type C fibers, they have lower firing rate. So as you can see here, they reach a level of about 35 action potentials per minute. And the maximum firing or the saturation for type C fibers is beyond 220. So beyond this figure here. And another thing, type C fibers are more abundant or more numerous compared to type A. So we have in our body more baroreceptors of type C compared to baroreceptors of type A. So the baroreceptor reflex, it is these are reflexes initiated by baroreceptors. When we have a high mean arterial pressure, there is an increase in the stretch of receptors or the baroreceptors. This will lead to higher firing rate, and impulses will travel along the vagus and glossopharyngeal nerves to the medullary cardiovascular center, and this will lead to increase in the activity of cardio inhibitor center in the medulla oblongata, and this will decrease the heart rate. Also, this will lead to decrease in the cardio accelerator center, the center that is responsible for increasing the heart rate. If you inhibit this center, the heart rate will decrease, and also there is a decrease in the activity or inhibition of the vasoconstrictor center. If we inhibit this center, there is vasodilation in the circulation or in the blood vessels. On the other hand, if the mean arterial pressure drops, there is decrease or lower stretch of the baroreceptors. This will decrease the firing rate and will lead to the release of cardiovascular center from the inhibition. So we'll get all effects opposite to the above explanation. We have inhibition of the cardio inhibitor center, the center that inhibits the heart rate. So if you inhibit that center, heart rate will increase. There is stimulation of the cardio accelerator center, and this will lead to an increase in the heart rate, and stimulation of the vasoconstrictor center, and this will cause vasoconstriction throughout the vascular system, and this will increase the total peripheral resistance. Here we have a summary of all the explanation. When the blood pressure increases, what happens to decrease blood pressure back to normal, and also the opposite. When blood pressure falls below normal or we have hypotension, the sequence of events that will happen to increase blood pressure back to normal. What is the importance of the baroreceptor reflex? Baroreceptors are important in maintaining mean arterial pressure constant during changes in body posture. For example, changing from supine to standing or sitting position, because we know very well that gravity has an effect on the venous return. Therefore, the baroreceptors are important in avoiding big changes or variations in the blood pressure while changing position. Otherwise, the person will have postural hypotension, and this can lead to dizziness. Baroreceptors are not suitable for long-term regulation. Why? Because of mean arterial pressure, because they adapt or they reset rapidly to the new pressure level. And this phenomenon is called baroreceptor resetting. So if the blood pressure becomes high for longer period, they become reset. Their firing rate that had increased for a while will decrease gradually as if there is no increase in blood pressure, and we call this baroreceptor resetting. Adaptation of the receptor means decrease in impulse discharge from the receptor despite the persistence of the stimulus. So the baroreceptors firing rate will decrease despite the persistence of high blood pressure. That's why they are not suitable for the long-term control of mean arterial pressure, and that's why people, even having a high blood pressure, when they have hypertension, the baroreceptor reflex won't help them in reducing blood pressure back to normal. What are the other stretch receptors? We have other baroreceptors, and these are the veno-atrial mechanoreceptors or baroreceptors. Also, we call them the cardiopulmonary stretch receptors. They are located in the right atrium and pulmonary artery. They respond to changes in central blood volume, which is mainly in the form of venous return. Lying down or elevating the legs or increasing blood volume, for example, giving excessive amount of blood transfusion or intravenous fluid, will increase the venous return, and this will stimulate the veno-atrial receptors. This will lead to an increase in the heart rate, and we call this the Bainbridge reflex. Also, a decrease in the renal sympathetic activity, so we have less renin production, less angiotensin II, less aldosterone, so we have a higher urine production or urine flow. And also this will lead or will send signals to the hypothalamus and will decrease the antidiuretic hormone release, so more urine is formed, so we get rid of water and sodium from our body. There are other baroreceptors that are located in the coronary circulation. We call them coronary artery baroreceptors. They respond to changes in the arterial pressure, but more sensitive than the carotid and aortic ones. So they are more sensitive, they have lower threshold. Then we have the third type, the unmyelinated mechanoreceptors. They respond to distension of the heart, especially the left side of the heart. In the ventricle, the ventricular unmyelinated mechanoreceptors, they are stimulated during systole and they will lead to vasodilation. And this will help in reducing the afterload and better ejection of blood. Atrial unmyelinated mechanoreceptors, they are stimulated during atrial filling as the blood is coming back from the pulmonary circulation, and this will lead to a reduction in the heart rate. Now the second short-term controller is the chemoreceptor reflex. It is a well-known controller of the ventilation or pulmonary ventilation or breathing, but also it plays a role in the regulation of blood pressure. It is very similar to the baroreceptor reflex, except that it responds to chemical changes like low oxygen, high carbon dioxide, high hydrogen concentration or acidosis. As you know, we have central and peripheral chemoreceptors. So a low mean arterial pressure, less than 60 millimeter mercury, will lead to a reduction in blood flow to the carotid and aortic bodies, where we have the peripheral chemoreceptors. So this will lead or less blood flow to the carotid and aortic bodies, less blood flow to the peripheral chemoreceptors. They will get less oxygen, carbon dioxide will accumulate and hydrogen will accumulate in that region, and this will stimulate the peripheral chemoreceptors, which in turn will stimulate the vasomotor center and eventually will increase the mean arterial pressure. The third short-term controller of the mean arterial pressure is the CNS ischemic response. Severe or marked decrease in the mean arterial pressure less than 60 millimeter mercury, with maximal response when the blood pressure drops to very low levels between 15 to 20 millimeter mercury. There is marked reduction in the cerebral blood flow, which will lead to decreased blood flow to the vasomotor center in the medulla. Carbon dioxide will accumulate there, and this will initiate the CNS ischemic response. It is a very strong sympathetic stimulation of the cardioaccelerator and vasoconstrictor neurons. This will lead to major vasoconstriction and cardiac acceleration. And this will lead to an increase in the mean arterial pressure. We call this response as the last ditch stand, because this will try, or the last reflex that will try to save our life when there is marked decrease in the mean arterial pressure. Now let's go to the intermediate term control, and we start with the first controller, which is the renin angiotensin vasoconstrictor mechanism. I didn't say aldosterone because aldosterone requires longer time to produce its effect, so aldosterone is with the other hormones under the long-term control of blood pressure. So here we are depending on the effect of angiotensin II. I will explain this quickly. Dehydration, hyponatremia or sodium deficiency, or low blood volume due to hemorrhage or dehydration, all of them will decrease blood volume. A decrease in blood volume will decrease blood pressure, and this will lead to a reduction in the renal blood flow. Reduction in the renal blood flow will stimulate the juxtaglomerular cells of the kidney to produce the peptide renin. Renin will act or will activate the inactive plasma protein that is produced by the liver, which is called angiotensinogen, into a partially active peptide, which is angiotensin I. Angiotensin I, as it flows through the pulmonary capillaries that express the ACE enzyme, angiotensin converting enzyme, will be converted to the more active peptide, which is angiotensin II. Angiotensin II has two effects. One of them is vasoconstriction, and this will increase the mean arterial pressure, and if we increase the it will increase the total peripheral resistance, and if we increase the total peripheral resistance, this will lead to an increase in the mean arterial pressure. So this is considered as an intermediate term control of this renin-angiotensin system. Also, angiotensin II will lead to or stimulate the adrenal cortex to release aldosterone, but as I said, this will need longer time, so the aldosterone will be under the long-term control of the mean arterial pressure. The second factor in the intermediate term control is the stress relaxation mechanism. So what happens here? We have an increase in the mean arterial pressure, or gradual increase in the mean arterial pressure. This will lead to stretch the blood vessels and keep stretching them more and more for minutes to hours. The pressure in the vessels will fall towards normal gradually. So gradual increase in blood pressure will stretch the blood vessels gradually, and this stretch will take minutes to hours. And as the blood vessels are stretched, they can accommodate this larger volume of blood with its pressure. So this will lead to gradual reduction in the blood pressure back to normal. It is called stretch relaxation mechanism. This continuing stretch of the vessels, called the stress relaxation, can serve as intermediate term pressure buffer. So it is an important mechanism in the intermediate term control of mean arterial pressure. The third factor in the intermediate term control is the capillary fluid shift mechanism. This will shift fluid through the tissue capillary wall in and out of the circulation to readjust the blood volume as needed. So when we need higher volume, fluid will shift from the interstitium to the blood, and if we need less blood volume, then the fluid will be shifted from the lumen of the blood vessels into the interstitium. And again, this is one of the intermediate term controls of the mean arterial pressure. Now let's talk about the long-term control of the mean arterial pressure. We have the renal blood volume pressure control mechanism. Renal blood volume pressure control. So the kidneys will control the blood volume, and if we control the blood volume, then we can control the blood pressure. That's why we have this name for this control mechanism. The kidneys control the level of water, sodium in the body, thus they can control the volume of the extracellular fluid, including the blood, which is one of the extracellular compartments. By controlling the blood volume, the kidneys can control the mean arterial pressure. This renal control is mediated by two different mechanisms. One of them is a direct effect of the high blood pressure. It is called pressure diuresis and pressure natriuresis, where in this case an increase in the mean arterial pressure will increase the glomerular filtration rate, or the GFR, which will increase the renal output of water and sodium respectively. And as I said, this is a direct effect of the high pressure on the GFR and the output of the kidney in terms of water and sodium. Another mechanism under the renal control, or another player in the renal control mechanism, are the hormones. And we have different hormones. We have the renin, angiotensin, aldosterone. As I said previously, aldosterone needs time to become a player in the mean arterial pressure. We have the antidiuretic hormone antidiuretic hormone ADH, which is called also vasopressin because it can cause vasoconstriction. It is released from the posterior pituitary gland. And we have the atrial natriuretic peptide, the hormone AMP. Here we can see the pressure diuresis. As you can see in this figure, as the arterial blood pressure increases from 60 to 200, the urinary volume, or the urinary output volume, will increase gradually. And this is called pressure diuresis, and it is a direct effect of the high pressure on the amount of water output by the kidneys. The same also applies for sodium. We have something called pressure natriuresis, which is the effect of high blood pressure on the clearance of sodium through the urine. The long-term control also includes the effect of hormones, and we start with aldosterone. It is the same slide that I have explained earlier, but here angiotensin II will lead to the stimulation of adrenal cortex to release aldosterone. Aldosterone will cause the sodium and water reabsorption or retention by the kidney. If we retain sodium, water will be retained by osmosis, and this will increase the blood volume. If we increase the blood volume, we are increasing the cardiac output, and this will increase the mean arterial pressure, as I have explained earlier in this lecture. The second hormone that plays a role in the long-term control of mean arterial pressure is the hormone antidiuretic hormone, or vasopressin. It is a peptide hormone released from the posterior pituitary gland in response to hyperosmolarity, especially when we have dehydration, sympathetic stimulation due to a decrease in the mean arterial pressure or decrease in the blood volume. Also, angiotensin II can directly stimulate the posterior pituitary gland to release antidiuretic hormone. And the fourth stimulant is decreased baroreceptors and arterial receptors firing. This hormone causes renal fluid retention by increasing water reabsorption, and if we increase the water reabsorption, this will lead to an increase in the blood volume, an increase in the venous return, and an increase in the mean arterial pressure. Also, this hormone, as its name depicts, it causes vasoconstriction, and if we have vasoconstriction, this will increase the total peripheral resistance and will increase the mean arterial pressure, because we know that the mean arterial pressure is a product of cardiac output and total peripheral resistance. The third hormone that is involved in the long-term control of mean arterial pressure is the hormone atrial natriuretic peptide, the hormone AMP. It is released in response to stimulation or distension of the atrial receptors. So the atrial wall is the source of this hormone. When the atria are stimulated by distension or overstretched due to increased venous return, this hormone is released into the blood. This hormone main function is to increase, as the name depicts, natriuresis, so the loss of sodium in urine. So it increases salt excretion via the kidney by inhibiting sodium reabsorption in the distal tubules of the kidney. It reduces water reabsorption in the collecting ducts, because we know that very well that water usually follows sodium. It also dilates the afferent glomerular arteriole and constricts the efferent glomerular arteriole, and this will increase the GFR, the glomerular filtration rate, and increase urine flow. AMP also inhibits the hormone, the secretion of aldosterone hormone from the adrenal cortex, and inhibits the release or secretion of renin from the juxtaglomerular cells of the kidney. So all these effects will lead to the loss of sodium in urine and followed by water. So we have higher volume of formed urine, and this will decrease the blood volume and decrease the mean arterial pressure. Here we see a summary of the main controllers of the mean arterial pressure. You can see here the mean arterial pressure. It depends on the cardiac output and the total peripheral resistance. Cardiac output is the function of heart rate and stroke volume, and both of them depend on several factors, sympathetic and parasympathetic, and the venous return that depends on the blood volume, respiratory activity, skeletal muscle activity, and so on, as well as the cardiac suction. And the total peripheral resistance depends on the viscosity, that is mainly dependent on the the red blood cell count, or the number of red blood cells, and the arteriolar radius, that is affected by local metabolic controllers and the extrinsic vasoconstrictor control, mainly the sympathetic division of the autonomic nervous system, plus the epinephrine hormone from the adrenal medulla. Please notice here that we have these two, the hormone vasopressin and the peptide angiotensin 2 can also affect the blood vessel radius as extrinsic controllers, because during the lecture I said the extrinsic controllers are neural in the form of sympathetic activity and hormonal in the form of vasopressin, epinephrine from the adrenal medulla, and also the peptide angiotensin 2. With this slide, I will summarize the controllers of mean arterial pressure. Altering any of the pertinent factors that influence mean arterial pressure will change this pressure, unless a compensatory change in another variable keeps the blood pressure constant. For example, if I increase the cardiac output, the mean arterial pressure will increase. But if at the same time the total peripheral resistance will decrease, the decrease in the total peripheral resistance will offset the effect of cardiac output increase on the mean arterial pressure. Blood flow to any given organ depends on the driving force of the mean arterial pressure and on the degree of vasoconstriction of that organ's arterioles. So if we have vasodilation with an increase in the mean arterial pressure, this will further improve the blood flow to that organ. Because mean arterial pressure depends on cardiac output and the degree of arteriolar vasoconstriction, if the arterioles in one organ dilate, the arterioles in other organs must constrict to maintain an adequate mean arterial pressure. Because if the blood vessels in all organs dilate at the same time, this will lead to dramatic decrease in the total peripheral resistance and dramatic fall in the mean arterial pressure. An adequate pressure is needed to provide a driving force to push blood not only to the vasodilated organs but also to the vital organs like the brain, which depends on a constant blood supply. Thus, the cardiovascular variables must be continuously balanced to maintain constant blood pressure despite organs' varying needs for the blood and its nutrients and oxygen. With this slide, I end today's session. Here is the list of references. Thank you very much for your patience and wish you all the best.